In this lecture, we're going to be talking about heart failure. And what you need to be able to do is conceptualize where the signs and symptoms of heart failure come from based on the pathology, what the signs and symptoms are, the different testing modalities that you should and should not do for heart failure, how to treat heart failure, and then how to identify the CHF exacerbation. Let's start off by constructing the model I want you to use to understand where the symptoms of heart failure come from. I want you to see the heart as actually two systems, a right ventricle and a left ventricle, lungs in between. The right heart pumps blood to the left heart through the lungs, and the left heart pumps blood throughout the entire periphery to the body, which acts as a resistor. Venous blood returns to the right ventricle, and the system begins anew. We're going to use this because you have to remember blood is going to back up before the broken pump. We're going to use this to talk about the difference between right and left heart failure. Most of the time, a patient will have both. There are cases, acute MI, where there's only left ventricular dysfunction. There are cases, like cor pulmonale from a PE or COPD, where there's isolated right failure. What you're going to see most of the time in people who have heart failure is elements of both. So if the pump breaks, that is, the right heart is lost, fluid is going to be backed up before the pump. That is, in the periphery, in the IVC and the SVC. It's going to go both directions. And because of that, there isn't really a whole lot of blood being pumped through the lungs. So not a lot of blood gets to the left ventricle, and not a lot of blood gets out to the periphery. Hang on to that. We'll use this to explore the symptomatology in a minute. Versus the person who has the left pump in dysfunction. The right ventricle is working fine, so all of the blood that comes back to the right ventricle from the periphery is pushed forward. The problem is that it can't get out of the left ventricle, and fluid backs up before the broken pump. So the lungs are going to drown in excess fluid. And because the left heart is broken, not a whole lot gets out to the body. So if we look at a person, we can begin to develop the signs and symptoms of heart failure. If the right heart is broken, fluid is going to back up before the right heart. It's going to be in both the SVC and the IVC. So if you look, what you will see is jugular venous distension, a product of fluid backing up into the SVC. Because of the gravity, most of the fluid is going to go down to the floor. What you'll see then is peripheral edema. But it has to go through the belly first. So you may see hepatosplenomegaly and what's called congestive hepatopathy, laboratory abnormalities of the liver because of heart failure. Because not enough blood is getting from the right to the left heart, the organs are going to feel a little funky, right? The person is not going to feel well. And so what you'll see is dyspnea on exertion, even with right heart failure. In left heart failure, all this fluid is all over the lungs. So what you're likely to see are some crackles. But now, if someone's upright, the fluid all kind of layers out down. You get a lot of lung zones open for oxygen exchange. If you lay flat, the fluid layers out differently and you compromise all lung zones. That's where you're going to get the orthopnea and paroxysmal nocturnal dyspnea. Orthopnea being short of breath when you lay flat. If you have those three things, dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea, waking up in the middle of the night, running for a window or refrigerator to relieve your sense of dyspnea, you got heart failure. So these are the classic symptoms. But as that fluid goes through the belly, you may have abdominal pain. And since all this fluid is developing in the lower extremities, you might get some weight gain. And then there are some findings of the heart. What you're going to look for is a displaced PMI, usually downward and laterally, and an S3. If you hear a displaced laterally PMI or S3, just like these three together, it's heart failure. So what I want you to see is that really there's two pumps, right and left, and the fluid is going to accumulate before the broken pump, presenting with different symptoms. Most of the time you're going to see somebody with all three, dyspnea, exertion, orthopnea, and paroxysmal nocturnal dyspnea, who's got crackles in their lung and peripheral edema from their toes to their ankles, from their toes to their hips. They may have some abdominal pain, they may complain of weight gain. Now there's some other symptoms that go in here, but it's kind of an advanced topic. All I want you to see is fluid accumulates, you'll be able to see it and hear it while the patient feels it. Then comes a diagnostic step. What do you do to diagnose heart failure? There's a couple of things you can do that you shouldn't. The chest x-ray, don't do it. While you may see signs of CHF exacerbation, curly B lines, pleural effusions, you don't know those things are from heart failure. And while you may see cardiomegaly, you could presume heart failure, but it doesn't help you. The chest x-ray is not good for diagnosing heart failure. The second thing is the EKG. Not useful for detecting heart failure. You might get a clue to the etiology, left ventricular hypertrophy, arrhythmia, coronary artery disease, but the EKG doesn't tell you heart failure or no. What helps you in terms of blood tests or non-invasive testing is the brain natriuretic peptide, either the pro-BNP or the BNP, whichever one you happen to have. Look for brain natriuretic peptide. It's released when the right atrium stretches. So it is not specific for heart failure. Any form of volume overload, including end-stage renal disease, will elevate the BNP. But chances are, if they're in heart failure and they've got fluid backing up somewhere, it's going to impact the BNP. So if the BNP is not elevated, it significantly reduces the chance that this patient has heart failure. So it's the place to start. Where you want to get to, though, where the money shot is the 2D echocardiogram. Because it is going to give you a lot of information. It's going to give you the ejection fraction, the pulmonary artery pressure, and the diastolic function. Now don't worry about pulmonary artery pressures for now. That's in the pulmonary hypertension lecture. Don't worry about it in this lecture. This brings up the difference between systolic and diastolic dysfunction. Get to that in a minute. Ultimately, what you are going to do with every diagnosis of heart failure, some exceptions of course, is the left heart cath, an angiogram. What you want to answer is this ischemic or non-ischemic? And you'll notice that we didn't talk about the etiology of heart failure because frankly it doesn't matter. The treatment is not going to change. All that matters is it ischemic or not, because as we learned from coronary artery disease, if it's ischemic, they're going to need a little bit extra therapy. And the way you diagnose that is with the left heart cath. And of course, if they have blockages in their heart arteries, you can stent them or do a CABG or whatever. But the idea is BNP to start, echocardiogram to confirm. Left heart cath gives you the left ventriculogram. It's the best test to diagnose heart failure. And it also tells you ischemic or not. So what's this deal with systolic versus diastolic? This is a normal cross-section of a normal heart. It's got a thick left ventricle, but the lumen still accepts blood. In the case of systolic dysfunction, generally through ischemia, but it can be any etiology, the heart gets big and floppy. The walls are thinned out, maybe don't move so well. This person has trouble with forward flow. It can't get the blood out of the heart. It's a low ejection fraction. A normal ejection fraction is about 55%. Less than 50, you've got systolic dysfunction. Diastolic dysfunction, on the other hand, is the opposite. You start with a normal heart, and the most common cause is hypertension, but you can have anything, right? It could just be the muscle getting big and beefy against a lot of resistance, or it could be an infiltrative disease. In diastolic dysfunction, you're going to have a really thick ventricle. And a really thick ventricle has no trouble pushing, but has trouble relaxing. It can't let blood in. This is going to be from hypertension or for infiltrative diseases. In this case, you may even have an elevated ejection fraction, or at the very least, it is normal. Diastolic dysfunction is now called heart failure with preserved ejection fraction. Now, we're not going to talk too much about diastolic dysfunction because the treatment hasn't really been worked out yet. So what I want you to take away is if they have heart failure, treat them the same way, knowing that diastolic dysfunction is more about relaxation and systolic dysfunction is more about squeeze, about contraction. Okay. So how do you treat somebody? You do not have to know the New York Heart Association classes for your test, but I'm going to talk about them briefly because they're not that hard to memorize. The treatment of someone chronically with heart failure is going to be based on the New York Heart Association class, and there are 4. This is how you remember it. All these patients have heart failure. It's about the symptomatology. Class 1, no restriction. Class 4, shortness of breath at rest. 2 and 3 are somewhere in between. 2 can go about their activities of daily living, about their house, go grocery shopping, not exert themselves very much, no symptoms. Class 3s get short of breath with just moving around. No symptoms? No symptoms with ADLs. Symptoms with ADLs, symptoms all the time. But this isn't so important because they're not going to be like, oh, this New York Heart Association class 3, how do you treat them? It's useful in the sense that the treatment escalates the higher the class gets, so that every treatment that came before it is true for the classes that follow. You'll see what I mean in a minute. Every patient who has heart failure gets a beta blocker and an ACE inhibitor. If they can't tolerate an ACE, ARB is okay. So will every other class of heart failure. So everybody gets put on a beta blocker and an ACE inhibitor. Class 2 is going to be because of fluid. So as fluid begins to accumulate, you just got to get it off. And you do that with loop diuretics, like furosemide. In class 3, and I hesitate to use these words because you'll hear them, but I don't really want you to engage them. It's more about afterload and preload reduction. And you're going to have to go after both elements. And the way you do that are with medications called isosorbide dinitrate hydralazine. You'll recognize this as Bidil and spironolactone. You're not going to be playing with these medications very much, but just remember that if they're already on these and they're asking you to add something else, pick either isosorbide dinitrate hydralazine or spironolactone. I don't want to get into the specifics. If you want to know more, check out the intern content in CHF. Class 4 patients, they're going to die in a year. And you're really not going to have to answer questions about these, so I'll just say it out loud. The big thing to remember is inotropes, dobutamine or milrinone. But these are the patients who are going to need a left ventricular assist device, a transplant, patients that you're really not going to have to handle, probably not even going to see. But they're there. The reason why that dashed line is there is because of the AICD, the automated internal cardiac defibrillator. If a person has an ejection fraction less than 35% and they're not class 4, they get an AICD. The reason why you do that is to prevent sudden cardiac death. Ventricular arrhythmias are the thing that kill people with a depressed ejection fraction. There's some other things you can do electrophysiologically, but I don't want to go down that route either. What I want you to remember is if heart failure and EF less than 35% and not class 4, AICD. Now way back here we talked about ischemic or not. What was the point of that? Well, in the treatment of somebody who's got heart failure, if they are ischemic, we've learned in coronary artery disease, they need an aspirin and a statin. So everybody gets a beta blocker and ACE inhibitor. If they are ischemic cardiomyopathy, they get ACE inhibitor, beta blocker, aspirin, statin, which you'll recognize from the coronary artery disease as the treatment for coronary artery disease. As they begin to get worse, you add on diuretics and other medications till eventually they need bridge therapy to transplant or they die. But there's more to treatment of heart failure than just medications. So everybody is going to get smoking cessation. But what you're going to need to do is worry about fluid, right? You want to keep the fluid off. So naturally, you want to limit how much fluid they take. Limit the amount of fluid to less than 2 liters per day. And because water follows salt, you want to keep the salt load down. That is, you keep the sodium chloride to less than 2 grams per day. All right, so this is the person who's been in clinic. You identify the symptoms and the signs. You know how to work them up. You finished off the workup with left heart cath, and now you know how to treat them. What do you do when that person comes in a CHF exacerbation? They walk into the ER acutely hypoxemic. You know they've got CHF, or it's a first-time diagnosis, but it's very clearly volume overload. What do you do? So if someone comes in with a CHF exacerbation, you're going to do all the tests. Because what you're looking for is the cause of their CHF exacerbation. You're going to get a chest x-ray to see if they're volume overloaded. You're going to get an EKG to see if they're having a STEMI, or if there's an arrhythmia that's provoked a CHF exacerbation. You're going to get the BNP to confirm that they're volume overloaded, and check a troponin to see if they have an NSTEMI. You are going to do a 2D echocardiogram, but that's going to be tomorrow. So you have to make a decision about what you're going to do right now. So if all these things are negative, it's not heart failure and you need to consider something else. If the EKGs or troponins are positive, that is, it's a STEMI, this person is treated as an MI and they get Mona-Bash. Morphine, oxygen nitrates, aspirin, beta blocker, ACE inhibitor, statin, heparin, and they go to cath. But if these things are positive, that is, the chest x-ray is positive, the BNP is positive, but you've ruled out that really dangerous disease, the EKG and the troponins are normal, now you just have a regular old CHF exacerbation. Now the treatment for CHF exacerbation is more complicated than this, but what I want you to learn is LMNOP, which stands for Lasix, furosemide, morphine, nitrates, oxygen, and position. They're probably going to be doing the position part for you, right? They're going to be sitting up because they have orthopnea. You give them oxygen to support them through it while you get rid of that excess fluid. Now you can give venodilators like morphine and nitrates to sort of pool the blood in the legs. That way it keeps it off the lungs. And also you can use this in the setting of dyspnea. Morphine treats the dyspnea and nitrates can help with the blood pressure. LMNOP is sort of a dumbed down version of the treatment. So long as you recognize, give them oxygen, give them diuretics, get that fluid off, you're doing all right. And then you'll have to go back and figure out what was it that's tipped them off. Arrhythmia, heart attack, medication noncompliance, dietary noncompliance, etc. That's heart failure.